Good day, everyone, and welcome to the Foundation for Opioid Response Efforts webinar, Beyond Xing the X-Waiver. This discussion is part of our ongoing work to expand access to treatment for people with opioid use disorder. And we're thrilled to have you with us this afternoon. I'm Karen Scott, President of the Foundation for Opioid Response Efforts, also known as FORE. On today's agenda, we will include a brief overview and update on the Foundation's work and activities, and then really get into a discussion with our distinguished panel. Dr. Westley Clark will focus on some of the considerations and concerns about not having the X-Waiver in place, as well as what comes next. Dr. Laura Weinstein at Thomas Jefferson University on considerations for medical education to improve access and quality of care for people with OUD. And Dr. Alistair Martin will talk about some of the innovative ways to really change provider behavior to better treat patients with opioid use disorder. Our goal is to have a discussion amongst our presenters and take some questions from the audience towards the end of our webinar. As a reminder, this webinar will go for an hour and a half, so we will end at 4:30 Eastern time today. And our next slide. So a couple of logistics. We are recording the webinar and we will make that available to everyone shortly after the session ends. And you can find that on our website, which is listed on this slide. We will also make the slides available for download on our website. We invite your participation and your thoughts and questions. So please use the Q&A button, which is found at the bottom of your Zoom screen. And you'll see there too, if you have questions that others are asking, if you see a similar question to yours, you can upvote using the thumbs up button on the question. That will allow us to try to prioritize some of the questions of most interest to the audience. Finally, there will be a brief survey immediately following the webinar. Please provide us with feedback, help us think about what other topics we might do as webinars, as well as other work that we could be considering as a foundation. Thanks. So just a brief update on the Foundation's activities and work. As of yesterday's grants announcement, we've awarded 74 grants since our first announcement in March 2020, almost exactly 3 years ago. And with those awards, have committed close to $34 million towards work to address solutions to the opioid crisis. We're a national foundation, so we put a lot of focus into making sure we're partnering with organizations across the country in many different types of communities and areas of the country, recognizing as well that the opioid crisis and overdose mortality looks different for different communities and in different parts of the country. Please visit our website to learn more about our grantees and the products and work coming out of our current grants. The Foundation was launched in 2018 to inspire and accelerate solutions to the opioid crisis. And our overarching framework for this work is to support work across professional education, payer and provider strategies, policy initiatives, and improving public awareness. And the specific topics of our program so far include a significant focus on access to treatment. In fact, those grants launched our grant making and our first set of projects in March 2020, very much with a focus on vulnerable and high-risk populations. During the early months of the pandemic, we pivoted to support recovery organizations so they could stay connected to people in recovery, as well as set up an infrastructure for evaluating some of the temporary changes during COVID with respect to access to treatment, some of those temporary regulatory policy changes. Last year, we launched an innovation program focusing on some of the more intractable problems of the crisis, such as addressing stigma, as well as generating more timely and actionable data. And we also launched a program focused more on upstream prevention, our family and community-based prevention for children and families at risk. Coming very soon, we will be announcing our first community-based organization grants under our community-driven responses to opioid use disorder and overdose mortality. These are capacity building grants to smaller community-based organizations. And again, please stay tuned to those exciting announcements in the next few weeks. I'm going to turn it over to our program director now, Dr. Ken Schatzkus, who's going to speak a little bit more about what we've learned so far from our access to treatment programs and how that drives our continued program development and the conversation today. Ken?
Thanks, Karen. All right, so let me just jump in here. I'm going to mute you and take your video off quickly. So our access to treatment program, as Karen said, was the first program that we had here at FORE, and very well connected to current events. We are all here today to talk about the removal of the X-Waiver and what comes next. And we all know that at the end of last year, President Biden signed the omnibus, which removed the requirement to obtain a specialized waiver to prescribe buprenorphine for opioid use disorder. But even before this, FORE recognized that Xing the X-Waiver by itself may not actually drive an expanded access to treatment that we are all hoping for, particularly to those vulnerable populations and populations that really need it most. So we wrote this health affairs article after a grantee meeting where we brought together a number of FORE grantees to discuss what really is it going to take to expand access to treatment, and encourage you all to take a look at it. But to provide some highlights quickly and to frame our conversation for today, we knew that getting waivered beforehand was really only the first step towards expanding access. We knew that only 8% of eligible practitioners had an X-Waiver when the X-Waiver was removed at the end of 2022. And we also knew that most X-Waiver providers did not treat any patients at all. And half of all buprenorphine prescriptions from 2016-2017 were prescribed by only 5% of all X-Waiver prescribers. So we're getting even smaller and smaller numbers. That is research from our FORE grantee, Brad Stein at RAND. We know that most primary care providers right now, they've not received the training needed in opioid use disorder treatment and don't know how to connect patients in long-term treatment and recovery. So we know providers are going to need training in all settings. They're going to need mentorship. They're going to need coaching. And we're also going to have to address stigma around addiction and build that community of practice that's expected that we help opioid use disorder patients. Our grantees are doing exactly this. They're showing how to operationalize and be able to expand access to those areas that are hardest hit. And I want to show some examples quickly. So this was our first grantee program and access to treatment. And I want to point out 3 of them right now quickly. So our first one's the Alaska Native Tribal Health Consortium, which is focused very much on expanding access to the very rural tribal regions of Alaska. And the idea here is to use telehealth as a way to reach those individuals and use a Project Echo model to train providers around the state to expand access. Our grant to UNC Health Sciences at Mountain Area Health Education Center was in partnership with the Dogwood Health Trust to build out a hub and spoke system, which we know has been successful in other states as well, as a way to, again, provide access in community health centers and other centers in and other centers around the states, but also to provide that intensive training and consultation to providers that are just getting started on buprenorphine. The last project I'll highlight is University of Alabama at Birmingham, where Dr. Lee there worked with a number of FQHCs around the state there to, again, expand access, but provide a resource to help train new providers that were just getting started on buprenorphine as well. Today, we're going to hear from other FORE grantees as well about, what they're doing in their roles and how they see that removal of the X-Waiver and what those next steps are. But I do want to highlight, as Karen mentioned earlier, that we are expanding our access to treatment program. We've heard over the past year about new barriers to being able to access buprenorphine at the pharmacy level, so dispensing. And yesterday we were able to announce $2 million in new grants that are aimed specifically at improving access to MOUD in pharmacies, as well as we funded a new phase of our grant to the American College of Emergency Physicians to continue to expand the work that we're doing and accelerate buprenorphine initiated treatment through the emergency room. You could read more about our grantees on our website right there. And now I want to bring back Karen in to introduce our webinar presenters. Sorry, Karen, you're on mute. I'll unmute you. You got it.
Thank you. So thrilled to have these presenters with us this afternoon. Dr. Wes Clark is, we're proud to say, is a member of the FORE Board of Directors. Wes is the former director of the Center for Substance Abuse Treatment at SAMHSA, also among many titles, a distinguished fellow of the Society for Addiction Medicine. Dr. Laura Weinstein is Associate Professor of Family Medicine and Program Director of the Addiction Medicine Fellowship at Thomas Jefferson University. And Dr. Alistair Martin, Emergency Room Physician, Assistant Professor of Emergency Medicine at Massachusetts General Hospital, and has led the program called Get Waivered to expand access to treatment in emergency departments. Again, welcome to our presenters, and I'm thrilled to turn it over to Dr. Clark. You're on, Wes.
Yep. Thank you. Can you hear me?
Yes, we can.
All right. I want to thank everyone for being on this webinar. It represents an opportunity for us to explore the next phase of use of the buprenorphine and other medications for the treatment of opioid use disorders. While our specific focus is on buprenorphine, there are other medications that can be used for the treatment of opioid use disorders. As we well know, methadone and extended release naltrexone. Some of you may be aware that there was a bill that was introduced this month, introduced in Congress, that would allow methadone to be prescribed by appropriate clinicians. We'll see how that bill makes progress. But in thinking about buprenorphine, that's what we're going to be focusing on at the end of the X-Waiver. Next slide, please. This slide, you can see data kept by SAMHSA that showed that at the end of 2022, there were 138,052 practitioners who had X-Waivers. 68% of these were physicians, 25% were advanced practice nurses, and the remaining 7% were physician associates / assistants, making up the remainder. In 2019, the DEA estimated that it had 1.8 million registrants, 1.8 million registrants. And you compare that to the 138,000 waivered practitioners, and you realize how few prescribers actually stepped up to address the issue of opioid use disorders, despite the escalating number of people dying from overdoses. With so few prescribers with waivers, you might ask, what did the federal government do to promote workforce and clinical support efforts? Next slide, please. SAMHSA, the Substance Abuse Mental Health Service Administration, did weigh in on this issue. And as you can see from this slide, SAMHSA had several programs that funded activities in both OUD and substance use disorders. The Cooperative Agreement for Providers Clinical Support System for Appropriate Use of Opioids in the Treatment of Pain and Opioid-Related Addiction. So from 2007 to 2017, $7 million, basically it was $500,000 a year. It went to either ASAM or AAAP. The SAMHSA adopted a provider's clinical support system in 2018 with $12.1 million from 2018 to 2021 to 150 entities. They've re-announced this program with $18 million being made available. The Screening and Brief Intervention Program, I have data from 2009 to 2015, where $26 million were spent to 198 grantees. The total workforce funding was $45.62 million. Next slide, please. On this slide, you can see the number of behavioral health education programs funded by HRSA, including an opioid workforce expansion for both professionals and paraprofessionals. In 2020, HRSA started funding an addiction medicine fellowship. Thus far, over 130 training programs have received funding. Based on my cursory review of the HRSA portfolio, HRSA has spent over $645 million on behavioral workforce efforts. So HHS, if you look at it from the department's perspective, has spent over $700 million over a 15-year period training practitioners. Still, only 138,000 practitioners had an X-Waiver. A lot of money, and it would appear not much bang for your buck. Next slide, please. Nevertheless, after hearing from organized medicine, the Congress decided to eliminate the X-Waiver. So people said, well, we don't want to do the continuing education, and we don't want to file an extra piece of paperwork with the DEA to let them know that we're interested in treating people with substance use disorders. In fact, on January 25th, the White House celebrated the death of the X-Waiver. And my response is, I certainly hope that the celebration was not premature. Next slide, please. With the death of the X-Waiver, what do we expect? We hope for increased access to treatment. We hope for reduced stigma. We hope for increased flexibility for healthcare providers. And we hope for improved patient outcomes. The key theme is in this last bullet on this slide. By increasing access to buprenorphine, we hope that patients may experience improved outcomes, including reduced cravings, withdrawal symptoms, decreased opioid use, and improved social and occupational functioning. We also want to make sure, under the third bullet, increased flexibility, that people have access to buprenorphine. Next slide, please. We can see from this slide that there are positive, negative impacts of the removal of the X-Waiver to prescribe buprenorphine. The risk of misuse or diversion. We don't want, as a result of the removal of the X-Waiver, an increased risk of misuse or diversion. Fortunately, data show that this is not a large problem and probably will not happen. Still, there have been practitioners who have been at least dinged by the DEA, if you can consider being dinged by the DEA dinging, because of misprescribing behavior. We don't want a decrease in quality of care. It has been argued that prescribers didn't need the X-Waiver to prescribe controlled substances for pain or other purposes, so why did they need an X-Waiver? That was a good question, but prescribers helped get us into the opioid epidemic, so that claim in and of itself is insufficient. A review of the announcements from the Department of Justice revealed a number of prescribers, from physicians to nurse practitioners, physician associates, misprescribing opioids. This is an ongoing issue. So we have to deal with it. Next slide, please. Healthcare providers who are not adequately trained in the treatment of OUD may be more likely to prescribe buprenorphine inappropriately or to patients who do not have an OUD. You don't really need to have major symptoms to meet criteria under the DSM-5 for an OUD. So that is an issue. There is the issue of liability claims. It's always a concern for prescribers, for practitioners. Buprenorphine is not water. And although it seems to have few adverse effects associated with it, there are the possibilities that complications can result. Finally, we have to convince enough prescribers to get additional training and mentorship. That becomes an issue. The challenge is, do I need any training to prescribe buprenorphine? Not to write the prescription, but what am I treating? The question is, what are you treating? And you have to have some sense of what you're treating and how to treat it. No place else in medicine is it simply assumed that just because you have a license that you should be able to treat something. I'm a psychiatrist. Theoretically, my license says a physician and surgeon, and I should be able to do also appendectomies and other surgical procedures. I wouldn't bet on it. So that is an issue that we have to take into consideration. Next slide, please. There's the issue then of data. With the X-Waiver, we were able to track at least and identify practitioners who had X-Waivers. We could do random sampling of those practitioners to determine what their experiences were. Without the X-Waiver, we need to figure out how to get that data. We can utilize prescription drug monitoring programs, PDMPs. The government can use that which will give us information as to who's prescribing what. We can conduct surveys and do research based on those randomized surveys. We can use Medicaid, Medicare claims data. That should help. We could use IQVIA data, which is data collected by private entities. We also can use NISDA data as a way of collecting data, but the need for data does not disappear with the disappearance of the X-Waiver. We need to work with healthcare organizations like hospitals and clinics to collect data on their experience and their use of buprenorphine. I do know that SAMHSA uses hospital-based data for their DAWN study, a good source of information, but we need that information. And that information is influenced by, next slide, please, the use of electronic health records. The government may utilize these EHRs to collect data. And then finally, if we can't get enough information, there may be the issue of government establishing reporting requirements for healthcare providers to prescribe buprenorphine, requiring them to produce that information. And this means not just the federal government, but state governments as well. Next slide, please. So the X-Waiver was an illusion as far as I'm concerned. The education requirement was de minimis 8 hours. As a licensed physician, I have to do at least 25 hours of CME every year. I found the whole objection to having to do 8 hours of addressing the issue of addiction somewhat disingenuous. But we can see from this slide that we have, for physicians, we have roughly 94,000 who were waivered, but there are an estimated number of practitioners, 1 million physicians, and that number is hard to pin down. AAMC collects some data and others. We have 139,000 PAs, 355,000 nurse practitioners. You add it all up, you get 1.5 million practitioners who did not have waivers, but who should be able to help in the treatment of opioid use disorders. Next slide, please. When we look at the barriers to MOUD care, we can look at the barriers that were identified for the X-Waivers. And Russell and his group pointed out that the ability to intervene on opportunity and motivation are complicated barriers that are likely to relate to discomfort with the unknown, pervasive stigma against people with SUDs and concerns about administrative and legal regulations. These are the real things. They pointed out, our survey shows that mid-career providers who did have waivers overwhelmingly felt that MOUD is an important treatment, and yet most were likely to refer all of their OUD patients to specialists for management. And then finally, the Office of the Assistant Secretary of Planning and Evaluation noted that even though the Biden-Harris administration liberalized the practice guidelines for the use of buprenorphine, they didn't find an acceleration at the national level in the number of patients with OUD filling buprenorphine prescriptions following the release of the practice guidelines. Next slide. So we have to keep in mind then we need a more aggressive effort to reach practitioners so that they can treat people with OUDs. Clinicians need to be educated. Professional clinical organizations can provide training on evidence-based treatments such as buprenorphine and other medications for OUD. Professional clinical organizations can promote cultural competence by educating clinicians about the unique experiences and needs of different populations, including marginalized groups that may be disproportionately affected by opioid use disorder and other substance use disorders. Next slide, please. We have to address the issue of language, non-stigmatizing language when referring to opioid users. We need to abandon things like addicts and junkies and adopt things like person with an opioid use disorder. CME training should be oriented toward reducing stigma and misconceptions about opioid users. Working with peer organizations like FORE, CARD, NAMA, and other peer-run organizations can help, and advocacy groups like Stop Stigma Now can also help. Professional clinical organizations can advocate for policies that reduce stigma against opioid users, such as funding for harm reduction programs and the elimination of discriminatory practice, such as arbitrary drug testing. Next slide, please. We need to share success stories, and that becomes important. Provide support, address concerns about addiction. If you're sharing success stories with primary care practitioners who have started this process and have found that they can successfully treat with buprenorphine and other medications people with OUDs, this will help overcome the negative perceptions and biases that some prescribers may have toward people with opioid use disorder. Support, SAMHSA has tried that with their PCSS programs to help people with guidance, mentoring, also support, and then address concerns about addiction. Some prescribers may be hesitant to prescribe buprenorphine due to concerns about addiction. So it's important to educate them that buprenorphine is safe, it's effective, can help patients overcome addiction, and we need their participation as practitioners. Next slide. There are administrative issues I've already mentioned once, and these people may be reluctant to prescribe buprenorphine due to these administrative issues, such as prior authorization requirements, insurance coverage issues. Addressing these issues can help to make buprenorphine treatment more accessible and convenient for patients, for physicians and patients. And we need to advocate for change, advocate for policy change at the state and national level that supports buprenorphine treatment, such as eliminating prior authorization requirements and increasing insurance coverage. States, localities, as well as the federal government should be actively concerned about these matters because, of course, every jurisdiction is coping with the issue of overdose. Next slide, please. Should think in terms of incentives for clinicians to use MOUD for those with opioid use disorders. So reimbursement for treatment. Prescribers should be reimbursed for the cost of buprenorphine or extended release naltrexone treatment for their patients. There should be performance-based incentives. Prescribers should receive performance-based incentives for meeting certain treatment goals, such as reducing opioid use and increasing patient retention and treatment. We should think in terms of quality improvement programs. Prescribers should participate in quality improvement programs that provide financial incentives for improving the quality of care provided to patients with opioid use disorders. Next slide, please. Other strategies could involve loan forgiveness programs to address the issue of maldistribution of practitioners willing to prescribe buprenorphine and other medications for opioid use disorders. Alternatively, continuing funding opportunities like SAMHSA state opioid response grants to make more resources available is an important theme. HRSA did have an incentive program, but that program went to clinics. So they gave clinics $3,000 to ensure that they had providers who were waivered. With the elimination of waiver, I don't think that would be as beneficial as providing incentives to clinicians. And then continued grant funding so that programs in, shall we say, impoverished areas or low practitioner areas can participate and make buprenorphine available. Next slide, please. The issue of equity. We need to keep in mind that we have 11 jurisdictions that are non-Medicaid expansion states. And there are 14.23 million people who live in poverty in those states. And so having access to buprenorphine may be compromised by the fact that they don't have, you have individuals in those states who don't have access to treatment. So we need to use block grants and specific funding to make sure that people in not just those 11 states, but all states who have an opioid use disorder can get treatment. Next slide. And then we should deal with the elephant in the room. As I pointed out, I don't think the issue with opioid use disorders was an issue of 8 hours of training or filling out an extra piece of paper. We fill out papers all the time. We apply for things all the time as practitioners, as citizens. The X-Waiver was just de minimis. The issue, I believe, is stigma and discrimination. Russell's comment about some of the other issues associated with prescribing should also be taken in consideration. Next slide, please. The elephant in the room is stigma and discrimination. And what we need to be doing is stopping stigma now. And if we can do that, then I think we can promote the expansion of buprenorphine to a wider array of practitioners, and that we don't have to worry about whether it's an X-Waiver or some other, quote, barrier to treatment. The barriers we can surmount, we have to get past stigma and discrimination. Thank you very much. Okay, our next speaker will be Dr. Laura Weinstein. She's Associate Professor, Department of Family and Community Medicine, Thomas Jefferson University. You're on, Laura.
Thank you so much, Dr. Clark. And I really, really do have to thank you for setting me up like this for my section of this presentation. And I'm really so grateful to be here to speak with everyone about a topic that I feel very passionately about, which is working with people who use drugs to reach recovery on their own terms in a healthcare system that meets their needs instead of the other way around. And I have to say, I truly have the best job in the world. I'm an academic family doctor, an addiction medicine specialist, and researcher. My clinical practice is a specialty practice and a satellite of a federally qualified health center. All the patients we see are formerly homeless and now in permanent supportive housing. There's about 500 of them. About half have a primary diagnosis of a serious mental illness, and half have a diagnosis of a substance use disorder. In our clinic, we offer full scope primary care, urgent care, wound care, and some days more than others, it feels like an ambulatory ICU. I will tell you, as a family doctor, I have learned so much about addiction from the people that put their trust in us and come to us as patients, and the dedicated staff who are truly supporting the people we work with to reclaim their lives. Next slide. I do not have too many slides, but I do have some things to say. I'm going to focus on stigma in the healthcare system because this is the system I live in every day, where I most clearly see the barriers and where I feel tremendous responsibility to do better. I truly believe without addressing stigma in the medical system, we will not overcome the opioid crisis, quite simply because the illegal drug industry is much further ahead of the medical system in terms of customer service. We have a lot of ground to make up. I like to approach complex problems by somehow slightly breaking them up into smaller chunks. It's somewhat contrived, but I feel that it helps us look at patterns and think about real world solutions. Next slide, please. So I'm going to start with beliefs, which is the most difficult of the three areas of stigma in medicine towards people with opioid use disorder. Now, sometimes beliefs are simply erroneous, such as a practitioner not understanding just how many morphine milligram equivalents a patient in the emergency department will need to overcome the withdrawal from fentanyl, which many of you already know is literally thousands of morphine milligram equivalents. Those are the easy ones. There are sometimes very entrenched false beliefs, and I believe they're so entrenched because they are almost a coping mechanism for healthcare staff in an attempt to avoid burnout in this very, very difficult environment where we are practicing, particularly over the last few years. And the way sociologist Irving Goffman defines stigma resonates with me quite a bit. He says, of course, this is a quote, "We believe the person with a stigma is not quite human. On this assumption, we exercise varieties of discrimination through which we effectively, if often unthinkingly, reduce his or her life chances." So not only is stigma not health promoting, it is truly deadly. I should say that these slides show a little bit about some of the efforts we've been able to initiate with the FORE Foundation, the FORE funding, and continuing on with them. So I will be getting to describe these a bit. After beliefs comes discomfort, or what can really transform into distress. Again, can be countertransference. I also see secondary trauma in some of my colleagues, particularly these days with the limb-threatening, terrible xylazine-related wounds, which is adulterating our supply here in Philadelphia to remarkable measures. Discomfort and distress can also be cultural. There is a subculture of folks who use drugs. And these are things we can learn about, we can be curious about, we can teach, we can ask our patients about. We can certainly have formal didactic sessions on trauma-informed care and harm reduction. We can also talk about some of the easy stuff, even ask our patients to help our students understand what a bag is, what a bundle is, what tranq is, which is what the folks we work with call the xylazine in the fentanyl supply. And also understanding the reality of the illegal drug trade, which our patients are dealing with every day. They're living in times of desperation and extreme poverty, and may start diverting some of their buprenorphine for survival reasons. And also pointing out that far and away, most of the people who are receiving the diverted buprenorphine are themselves benefiting from it. Not that we can condone this, but that is the reality, and there is some benefit from it. So some of the countermeasures that we've found very effective in terms of addressing beliefs and helping to decrease distress include student electives up here in North Philly at our federally qualified health center, where students have a remarkable opportunity to meet patients on their own terms in a truly low barrier patient-centered setting, which often is the complete opposite of how they encounter patients in the emergency department, in the wards, when the patients are really at their most desperate, at their worst. And frankly, the students and residents and everyone is overstressed, exhausted, not at their best. We were very fortunate to start our clinical addiction medicine fellowship during the period of the FORE funding, which really helped jumpstart some of our efforts in true community-based addiction care and training young doctors in how to do that. We now also have some areas of concentration in addiction in our family medicine residency. And we've worked on some simulations that I will talk about a bit more at the end. Next slide, please. So the third circle, service provision and being unprepared to provide services to people who use drugs, really could be the most straightforward area of stigma that we can develop countermeasures. We have so many advanced innovations in the United States healthcare. I am very frustrated, and I cannot understand why we make it so much harder than we need to develop effective systems to treat opioid use disorder. There's so many straightforward issues we can plan and prepare for. For example, in a practice just starting up, their MOUD program, they can know the pharmacies that stock the buprenorphine, what doses they typically have, whether it's tablets or films. Get to know your local pharmacist. So when the patient arrives, the pharmacist is ready and prepared to help that person. Know the right codes to order when you're doing drug screening. And even more importantly, anticipate issues with policies that allow us to maintain compassionate boundaries and safety for all involved. Any of us who work with people who use drugs realize that a lot of folks are in very desperate situations. Their neurobiology is in many ways overcome by the opioids. And when they first come to us for care, the place where we should be the most compassionate, they're often at their worst and are really struggling. Any of us who've been doing this for more than a year understands that people are going to lose their medications or run out early. They might bring in a urine sample that is actually not theirs because we have trained them to give us what they think we want. These are things we can talk about before we ever write a prescription for buprenorphine. We can have policies, we can have plans, we can discuss with our staff, we can debrief when these episodes happen, but we can be prepared ahead of time. So again, we can be consistent and compassionate towards the patients instead of completely caught off guard at the things that happen. They shouldn't surprise us. People are really in a desperate situation with severe opioid addiction, particularly in the hospital. The hospital and the skilled nursing facilities truly were not designed for young or middle-aged, but otherwise healthy people with really terrible acute conditions, limb-threatening, bone infections, heart infections. And these folks are withdrawing. Another issue that we don't generally address very well in an acute hospitalized setting. And particularly in this age of fentanyl. If we are not doing a good job of addressing someone's withdrawal symptoms while they're there for life-saving therapy, we really shouldn't be surprised that they might need to ask their friend to bring in some fentanyl, maybe in a hoagie or something like that. That happens in Philadelphia where we have hoagies. But we shouldn't be surprised and shocked. They're just trying to survive. And again, these are things with, compassionate training of the folks in security, compassionate training of how to, address quote unquote contraband. we know these things happen, and we can really do a much better job of addressing them. Some of the things we've done, again, during the period of the FORE Foundation was to be part of a preceptor program through the Health Federation of Philadelphia, where new, mostly federally qualified health centers could send some of their staff to work at some of our sites and sit in for a half day, see how we work things. One of my colleagues at Jefferson, who started really the first academic family medicine MOUD clinic, is working on rolling out a toolbox of academic practice support. And then providing service where people are, in housing, in homeless drop-in centers, in street medicine. Next slide, please. There's other critical overlapping areas that I really want to mention, particularly the importance of having peer staff on your team when you're offering medications for opioid use disorders. Peers, not only do they really know how to support patients in a way that providers simply cannot, they can also teach the rest of the staff of what is really going on and the reality that our patients are facing. One of the first things we did with our FORE funding was develop participant advisory councils at each of our 3 satellite sites of our federally qualified health center. And we had maybe 1 or 2 monthly meetings at each site before the pandemic. Fortunately, that was enough time to have a cohesive group, and we could continue to have virtual meetings throughout the pandemic time. These groups have been transformational and also very simple. It's asking the people most affected by the problem what they would do to solve the problem. And we continue to have ad hoc groups at any point in time to convene folks to comment on all new initiatives that we're coming up with. Next slide, please. And let me just, how am I doing for time here?
We're getting
Yeah.
a little tight on time. If we can run through the rest in the next minute or 2. Thanks.
Absolutely. Here we go.
We'll have time for discussion later.
Absolutely. I want to finish by talking about a series of demonstration videos we made with the support of FORE and an amazing production company called Rocket Ship. We solicited these ideas from our participant advisory councils, wrote the scripts, got feedback. We're planning to incorporate them into the curriculum by using them to prepare medical students for similar encounters by looking at specific points. Again, these give students and practitioners the words they may need to start talking to patients, and another way for us to evaluate how learners are doing in a simulated patient encounter after they've watched the videos. I'll end with this final slide of one of our videos for staff. We could make many more. Also shows an inevitable scenario of someone coming in and having withdrawal symptoms in the waiting room. We've had really terrific uptake of these videos. You can see this one has had almost 40,000 views since March 2022. And we're really looking forward to more great things. Thanks for the time. And it's my pleasure to introduce the next speaker. Just move out of my notes here. Bear with me. It's Dr. Alistair Martin, emergency room physician and assistant professor at Massachusetts General Hospital, talking about the Get Waivered program. Thank you.
Thank you so much, Dr. Weinstein, and thank you very much as well, Dr. Clark, and to the FORE Foundation. It's really given us the opportunity to push the initial work that we started many years ago at Mass General Hospital and disseminate the lessons learned and really get as many providers waivered as possible. The nature of the challenge now, as we've been discussing over the course of the last hour, is the X-Waiver has been X'd. But what I want you to take away from at least this part of the conversation is that I think the real work actually begins right now. You can go to the next slide. Okay, so imagine the year is 2017. Colin Kaepernick took a knee. J-Lo and Alex Rodriguez got together, and the best DC movie in history had been released, Wonder Woman. I will take no slander against the Wonder Woman collection of videos. And us at Mass General, if you go to the next slide, we were thinking a lot about how do we address this problem of increasing the provision of EDMAT. Our initial diagnosis broke this problem down into a couple of different subcomponents. We'll go through each one of those subcomponents, and you'll begin to see over the course of the next 10 to 15 minutes how our work was really targeted at trying to address methodically each one of these links in the chain. The first problem was that if we were really interested in getting folks to prescribe more MAT in our department, in our emergency department, we had, unfortunately, a barrier, and that was that few emergency department clinicians had their X-Waiver. So embedded in that was a question: how do you get clinicians to go the extra mile and get their X-Waiver? The second barrier, though, was that back then in 2017, we didn't have a protocol in place for ED, medication for addiction treatment. And so the sub-question that's buried in there is, even if you have a critical mass of waivered clinicians, does the hospital support ED, medication for addiction treatment? And then the third component of the problem, third chain in this link, is the barrier that many of you who do this every day and who are experts in this field understand already, and that is that changing clinician behavior is hard, it's challenging. The sub-question there is, even if you have waivered clinicians and you have an EDMAT protocol in place, how do you get folks to actually prescribe EDMAT? So we had to go through methodically and think about what will our interventions be for each link in this chain. You can go to the next slide. The work of Get Waiver was very simple, very straightforward. It was laser focused on this question: how do you get clinicians to go the extra mile and get their DAX waiver? You can go to the next slide. And so back in 2017, we started this admittedly cheesily named, it's a little bit of a dad joke, program, which was called Get Waiver, but I think it got the point across. At the beginning of the initiative, we had only 1 out of 42 physicians in our department who were attending physicians who had their DX waiver. The idea was to blend interventions and lessons learned from the field of behavioral economics, from design, and from public policy to try and identify how might you construct, right, a campaign that did not force people to get waivered, but instead allowed them to come to their own conclusions that yes, this was the right thing to do, and then persuaded them to take action to get their waivers. And by the way, we didn't have a lot of money, so we had to figure out how to do this with a tight budget. And so that then evolved into us developing, designing, and launching a campaign using design thinking and behavioral economics to try and push as many ED attendings as possible to get their DX waiver. What we did has been written about. We've got a couple pieces in the Annals of Emergency Medicine you can read more about. And that's not the scope of today. I'm not going to get into those interventions, but you can go to the next slide. As a result of those interventions, we ended up getting 95% of our department waiver. That's 40 out of 42 of our physicians. Briefly, for those who have put some questions in the chat, we used principles that adhere to things like social norms, right? How do you make it appear as if everyone is doing this already? So you might as well get along. How do you leverage authority, the authority principle? Well, it looks like the chair and the vice chair have chosen to get waivered. How about you? We used salience, which is we found patients who most of our department had taken care of in the past, patients with opioid use disorder, who many had thought were overdosed and who had died. We found them out in community, brought them back to the department, had them tell their story and say, look, the reason why I'm in community college now, the reason why I am engaged now, the reason why I've got my life back is because somebody cared, took the extra effort, and got me into treatment. And so we found that these 3 levers were the most effective when it came to leveraging behavioral economic principles to get doctors to do this extra thing and get them waivered. You go to the next slide. We took the show on the road. We partnered with a a whole host of stakeholders in the state of Texas to do a statewide get waivered campaign. This was obviously pre-pandemic. Remember, we're still in 2017. And it was really fun. It was a little bit like the nerdiest like concert tour you've ever been on. Like, you know, we went town to town and did these waiver training sessions back when it was 8 hours. My God. You can go to the next slide. And we then expanded the work nationally, thanks to the NIH, who did a spotlight on the work and helped us connect to partners across the country. You can go to the next slide. But things really, really hit an inflection point thanks to the FORE Foundation. You know, so now we're in 2020. We have this whole plan, you know, about how we're going to do this ground campaign, GOTV style, really focused organizing effort across the country, in person, getting people waivered. And then the pandemic hits. We had to scrap all those plans. And thanks to the flexibility, the foresight of the FORE Foundation, they gave us the leeway, the independence to really shape the model in a different way and adapt it. And so we created the Get Waivered remote course, which you see here. These were live web-based trainings. We opened them to all clinicians. And we not only taught about the waiver and got people their waivers, but we also made it specific. Okay, you're in Michigan. Here are the 5 resources we know that exist in Michigan, so you can start prescribing tomorrow. Okay, you're in California. Have you heard of CA Bridge? One of the most incredible organizations, California Bridge, most incredible organizations across the country doing this work. We need you to connect with them. Oh, you're in Florida. We've got 3 or 4 partners who are FORE grantees who we need to connect you with. So it was not just about getting the waiver. It was about getting plugged into a community. You go to the next slide. And so this remote course, this is kind of how it looks. We basically push this in every single venue we could using digital methods. You can go to the next slide. Yep, one more before that. And so one of the things that we did that was very, very, very useful was when people were in the course, we had them tweet out about it, amplify it, talk about it to their communities, so that every one person we got waivered, they could bring someone else in to get waivered. You go to the next slide. The other cool thing about this is that, you know, the flexibility of these online courses meant that clinicians who were in the middle of their busy lives could get waivered. And so this is an example of Dr. Jasmine Shaw, who's an ER clinician who's taking care of her baby while getting waivered. You can go to the next slide. Of course, we also recruited influencers. We recruited those influencers on TikTok. Didn't quite get Dr. Mike, but we tried. But a lot of worked with a lot of influencers as well throughout the country to help push the message and get as many people waived as possible. We can go to the next slide. So what happened? So over the course of the time that we worked on this FORE grant, thanks to the incredible support that we've been given, we were able to hold about 24 Get Waivered courses across the country. Each of them partnered with some anchor partner, like the Virginia Department of Public Health, the Ohio Department of Public Health, Centera Health, which is a big health system in Virginia, et cetera. We even partnered with YouTube Health. Now you can go to the next slide. And across the country, we were able to get about just over 5,000 clinicians help getting their waivers through our courses. You can go to the next slide. But let me now do kind of the disappointing, but also potentially inspiring pivot here. And that is, yes, we helped a lot of people get waivered, but look at this now, right? 1.8 million clinicians are now able to prescribe MAT after the passage of the MAT Act. But let me give you one other number, which is really important here. You go to the next slide. And that is that from the data that we've talked about, as Ken mentioned at the beginning of the call, there's some estimates that the vast majority of people, the majority of people who got waivered actually didn't even use the waiver. This one study found that 53% of those who were waivered didn't use their waiver. You can go to the next slide. And so coming back to our diagnostic pathway, right? These are 3 different components of the problem that we have faced back in 2017. Again, for us, we got to start first with getting people waivered, right? But then you can go to the next slide. Once we instituted our MAT protocol and had a robust number of folks who were waived, we locked in laser focus. How do you get people to actually prescribe this medication, right? How do you actually change clinician behavior? And it turns out, in this case, you go to the next slide. While we all know that changing clinician practice is hard, turns out there's a whole field called behavioral science or behavioral economics that has certain schema, frameworks, interventions that are proven to actually change behavior. And so you can go to the next slide. The critical juncture is this, what is known as the action intention gap. People intend, right, to prescribe buprenorphine. They intend to, they do, they mean well, but the action falls short. This is the field, this is sort of the arena of behavioral science. How do you move these two lines closer together? How do you increase the amount of action that's happening such that it matches the intention? You go to the next slide. And so back then we partnered with a behavioral economics firm called Ideas 42 to develop behavioral economic interventions or nudges to actually get doctors to prescribe. You can go to the next slide. Ideas 42, for those of you who may or may not know, they spun out of the White House Behavioral Nudge Unit back in the Obama era. They've worked with lots of different partners, the White House, City of Chicago, American Express, et cetera. So we partnered with them to look at this problem. You go to the next slide. Got a big grant from the Arnold Foundation. Go to the next slide. And began to really zero in on this question. What are the behavioral barriers to clinicians adopting this new MAT protocol? And how can we develop behaviorally sound interventions to try and nudge them to prescribe more often? You go to the next slide. We created decision action maps, which is the first step of any behavioral process. You go on observational studies, you walk with people, you sit with patients, you try to, metaphorically and sometimes physically sit next to or shoulder to shoulder with the person who is in the position of making that decision, and you try and understand with empathy what is it they're going through. How can we anticipate their concerns or barriers and address them? Next slide. So what did we learn after our interviews with patients and providers, after our observational studies, after sitting in the pocket with these clinicians and really trying to understand what was going on? There were 4 barriers. 1, the protocol was not easy to remember, even at our hospital, Mass General. 2, there were lack of cues to initiate conversations about opioid use disorder. 3, it was not top of mind for many clinicians, and thus it was likely to be deprioritized. 4, it was unclear whose responsibility it was to treat. Some docs thought it was a social worker's responsibility. Some docs thought it was the addiction nurse responsibility. It was clear that we had this sort of diffusion responsibility that was happening. You can go to the next slide. So what did we do for each of these barriers? The first barrier, where folks said it was hard to remember or access the protocol. Okay, no problem. We created a badge backer for you. There's the whole protocol right there. You get confused, you just look down. This is mine. Okay, I still wear this to this day. This is my ID. On the back of it, I have our protocol. And so do all of the other clinicians in our department have that protocol. It basically walks through exactly what dose, if you need a Cal scale, it's got the QR code there. And also scripting, okay? Look at that mnemonic. Physicians love mnemonics. They love them. Next slide. And this is using a principle called ease. You need to make it easy for people to do things, for them to actually do it. Next slide. Next, some folks said it was not top of mind. Okay, we're gonna make it top of mind for you. We created every month a success story and shout out to email. Dr. Karen Scott just last week helped a patient get onto buprenorphine, and the patient was a young pregnant mother who is now in her 3rd month of recovery, right? Basically calling out people for the good that they do. Why? Because in the emergency department, the only follow-up we get, that patient who, right, the blank is that comes after the patient who died or had a bad outcome. We decided to invert the narrative and give people good feedback about what was going on. And we called people out and publicly celebrated them. Next slide. That is leveraging a principle called salience. You have to make things memorable for people to actually take action. Next slide. Okay, some folks said, yeah, I don't know. We got social workers, we have nurses. It's not clear whose responsibility it is to treat this disease. Okay, well, for them, we leverage something called cognitive dissonance. You cannot wear, all right, an ID that literally, when it's hanging, right? I don't know if you guys can see this, but when it's hanging, it is a side of it is hanging out and effectively saying to not only you and everyone around you, right? I treat opioid use disorder. Look at the back of the badge. I treat opioid use disorder. Say it with me now. I treat opioid use disorder, right? So we were helping to change identity. Next slide. Next slide. And yeah, we're leveraging accountability. If you say you're going to do something, if you're going to wear a thing that says you treat opioid disorder, you probably should follow that up. Next slide. And then lastly, folks said it was hard to remember because there were lack of cues to remember. Okay, so what did we do there? We created a best practice advisory. This is an algorithm that reviews the computer, the electronic medical record, and sees if a patient would qualify for being put on opioid use disorder treatment. And if they are, it auto-populates a whole order set, okay? Naloxone, buprenorphine, bridge clinic follow-up. And so basically right then and there, a patient is given, the provider is given not only the reminder, but it's also easy for the provider to then start to make the behavioral actions that are needed to actually close the gap. Next slide. And this is just leveraging the principle of timely reminders. Next slide. So what happened? Well, what happened is when we did a regression discontinuity, we found not just statistically significant results, but clinically significant results. People prescribed buprenorphine. Next slide. Patients got into treatment, right? This is what it's all about. It's not just about getting people waivered. It's not just about doing more educational sessions. It's not more about CME. It's about, did you get patients to providers to prescribe more buprenorphine and get patients connected to a resource. And in this case, we did. One other thing I'll say about this, because cost is always a concern. Hospitals are losing billions over the course and have been over the course of last year, this post-pandemic place that we're in. These interventions don't cost anything for the vast majority of them, right? We're sending an email out. These IDs, right? $2 per, right? The BPA, yes, you might say, well, it takes time to do that. Yes, it does take time, but if it's worth it, you will make the time. Next slide. And so the bottom line is, going back to 2017, right, where we were, the nation's EDs are where we were back in 2017. We had a bunch of new prescribers in our hospital, 95% in our department, and yet we had to focus on how do you get them to prescribe. The question we're thinking a lot about now is, can we apply the interventions that we learned, the lessons we learned from that Ideas 42 partnered grant? Can we apply those interventions now in a distributed and a highly distributed and highly disseminated way to actually help clinicians treat OUD? For many, for the first time. So I'm so happy that FORE was able to bring us all together. Thank you for listening. I'm looking forward to the discussion.
Wow, Alistair, thank you so much. And thank you, Laura and Wes. I think everyone in the audience can see why we're excited about having all three of these presenters with us this afternoon. I'm going to see if we can get everybody back on the screen, our presenters. Great. And our terrific. I'm going to kick off our discussion section. We have a very active question and answer box as well, so I want to get to some of the audience questions. But let me start with one to pick up on this. This whole endeavor is a focus on expanding access to treatment. And I know none of us want to think about access without also thinking about access to how the quality of care that we're providing access to, and part of quality is also equity. It's also being patient-centered. Laura, you gave incredibly powerful examples of how to be patient-centered and address some of the stigma. But I wonder, Wes, if you could lead off and just say a little bit more about where we are in terms of providing access to care in an equitable manner, and some of the disparities that we know exist, and where we go next in terms of addressing those disparities.
Well, Laura and Alistair actually help characterize the disparities that do exist. In part, there are these issues, as was pointed out with regard to pharmacy deserts in terms of being able to get buprenorphine, being able to pay for buprenorphine. The same thing is true for not just buprenorphine. In terms of quality care and access to care, we need to keep in mind that there is extended release naltrexone. There are different formulations of buprenorphine. And there's the question of whether people need to be on buprenorphine or naltrexone at all. I mean, so the issue of patient-centered care allows you to work with the patient to make decisions. If we have maldistribution of practitioners, which we still have, I appreciate what HRSA is doing in terms of trying to outreach the family federally qualified community health centers and other kinds of health centers who will take low-income patients. So that helps promote equity. Other sociologists have pointed out that people of color were nudged toward methadone. If the new law changes, then your primary care practitioner will be able to prescribe methadone. But in the absence of that law, can you still get access to buprenorphine? Cost of it is an issue. Pharmacy deserts and accessibility issues. So we want the administration to be dealing with some of these systems issues. We want state authorities to be able to address some of these systems issues so that we can facilitate access. Strategies in terms of showing a compassionate practitioner, as Dr. Weinstein, Dr. Martin, with going to professional organizations, having these things integrated in meetings, AMA meetings, general family medicine meetings, et cetera. I remember going to the American Academy of Family Practitioner. I was on the last day and I was dealing with pain medication. Then you go 3 or 4 days, and as people are going out the door, they talked about this issue. So hopefully you move it from the last day to someplace in the middle so that people won't be dashing for the Uber, they'll be dashing to the room. So we have to deal with this, and having FORE promote this, having SAMHSA promote this. SAMHSA just announced a one grant for 1.5 million on alcohol medications. And that will fit in their PCSS opioid, which is $18 million. But is that enough? HRSA's got a portfolio for addiction medicine training of fellowships. I would like Dr. Martin to work with HRSA's fellowship program, because they fund these things. And so the question is, what's going on in these things? Just because you fund it doesn't mean that you're getting quality of care. You're dealing with people's attitudes. We need the sort of systems-wide discourse. NMA needs to be involved. Hispanic serving organizations need to be involved. American Indian, Alaska Natives, LGBTQ, senior citizens. How do you deal with, because at least in the Black community, we're dealing with a bunch of old addicts, quote unquote, as they would say, people who are in their 50s and 60s who, as Laura points out, still using and at risk for overdose with fentanyl, but still you have to be able to deal with that. So there is no place where substance use, where opioid use can be ignored. And so we need to be prepared to deal with that. And if you get a concerted effort at the federal level, at the state level, at the city and county level, at the community level, the faith community involved, community-based organizations involved, I think then we can begin to address this. If we're not doing it from a comprehensive perspective at multiple levels, including peer groups, as Laura pointed out, you're not dealing with the issue.
Yeah, thank you. So really I think we can think of the changes to the X-Waiver as a trigger to then launch all of the cascade of all of this other work that needs to be done as well, and all of the collaboration that needs to be done and communication across all of those levels. I just wonder, Alistair, if you wanted to add anything in terms of the quality and the equity.
Yeah, I mean, well, first of all, I think Dr. Clark nailed it. I think the only thing that I will add is sort of, as he referred to earlier, the elephant in the room. I think part of what is leading to the discrepancy in who gets MAT and who does not is actually bias, and it's providers sort of unconsciously, implicitly, over indexing and under indexing in certain cases for patients. And that part, I will say is it's a problem that extends beyond just the treatment of addiction. And so, we need sort of multifactorial solutions to try and, get the apparatus right? Let's make sure there's a, MAT protocol in the hospital. Let's make sure that folks know about it. Let's make sure they're not getting punished for using it or making it their lives incredibly difficult to use it. But then also we've got to be, focused on how do you actually also change the provider too, so that they are seeing through lenses that are not tinted. So yeah, that's all I would add. And I think that's going to take all of us.
Thank you. Thank you. Laura, it strikes us that, one opportunity that this discussion and sort of prompted by the removal of the X-Waiver might present is the ability for us to think more holistically about the system of care. And you've described a lot of that, and certainly your work exemplifies a lot of that. But rather than having the addiction treatment so siloed from everything else, as I think it has been for many decades, do you see this as an opportunity to really promote a more comprehensive approach to understanding what patients with OUD need and being able to drive a system to get us there?
I certainly do. And I feel really fortunate with the students that come to me. Some are going into orthopedics, some are going into ophthalmology. And at least in Philadelphia, if you're practicing medicine, you're going to see someone with opioid use disorder. And if you operate on them, you might even have to write their buprenorphine prescription till they can get back to their regular source. So the issue is with us. And frankly, I feel that if we can figure this out across our system, this will be the first step into humanizing our system for everybody. So the broader, we can learn, the better we can push all of us to be better.
Yeah, great, thanks. I'm going to turn, because we have so many questions, I want to turn and make sure that we get a couple of those in. And a number of people have comments and questions related to the current proposed changes around telehealth when it comes to prescribing buprenorphine and the requirement for, while it can be initiated remotely, still requiring a face-to-face visit, I believe within the first 30 days of starting. So maybe Wes, you could start off this round again. Any your thoughts on that proposed requirement in terms of whether facilitating access, hampering access, facilitating quality, hampering quality?
Well, we're currently, groups are currently thinking about this. We have time to respond to the DEA. And if you have an opinion, you should weigh in. I am not certain that it is a tremendous barrier, but there are others who believe that it is. So I will defer to the consensus. The most important thing to me is people being able to get access, and that indeed we don't lose buprenorphine because of waste, fraud, and abuse. There have been practitioners who have not been completely, shall we say, orthodox in their approach, and that has caused the DEA to be somewhat suspicious. Remember, the OIG has already said that it believes there's a lot of fraud in the substance abuse delivery system. They published that in their December 2020 final rule. So, and then we just had other doctors who, there's a drug treatment chain that just got busted for waste, fraud, and abuse and misbilling, et cetera. So that aside, the key issue is we have to demonstrate to the largest society why it is an impossible task and why it is a tremendous burden to expect to see someone. If you've got someone who's got injuries due to xylazine infection and you're not seeing them at all, then are you essentially creating a liability risk for yourself do you need to see someone at least once to figure out whether there are other health conditions? When you're dealing with poor people, there other health conditions are not uncommon. And we should be in a situation that we're just not treating one thing. We should be looking at the whole patient. So again, I would welcome people like Laura's and Alistair's opinion on the matter. And again, we're trying to decide whether we should be pushing back on the DEA's proposal or not. So it isn't opposing telehealth. It is saying that somebody needs to make sure that they check in with the patient. And I am concerned about quality of care. And so I know my colleagues and I are struggling with this, and some believe that it is an impediment. Others obviously don't. So the DEA is welcoming opinions, and we need to establish a logical basis for why it's a true impediment. Geographically, I know in rural areas it may be an impediment, but somebody someplace should see the patient. What are we treating? We should be treating something rather than pushing pills.
Thanks. Laura, do you want to add?
I agree, and putting your eyes on someone, especially in this critical period of their lives, is really critical. There's 2 times where I feel that it would be important to have the telehealth, and perhaps on the rare occasion have more than 30 days go past. And those are the highly traumatized folks that our street medicine teams are engaging with, who no way would come near a healthcare facility because of the way we've treated them. And they're ready to start buprenorphine. I'm going to give them a script, and if maybe the next time, I can do it again. The other time is some folks with the horrendous xylazine wounds who actually have an amputation, are at home and getting, this is the key, getting home nursing care. And the nurse can call, we can look, at the wounds, we can look at the person. To me, that's almost as good. And that person couldn't get in.
Great, thank you. Thanks. Alistair, we're going to turn to some of the questions from the audience, and we have a question that I think with the work you've done in making the content and the educational material available in so many different formats, I want to start with you on this, and it's a concern about how do we make sure that we're continuing to provide clinicians with up-to-date information in an environment where the drug environment is changing so rapidly and continuously. So Laura just mentioned xylazine wounds. I think if we'd done this webinar last year, we wouldn't have mentioned the word xylazine. So how do we, and that's not going to get covered by a one-time, right, CME of an hour on OUD that someone might do, might have done a couple of years ago. So how do we think about the best channels to really keep people updated? Because it's potentially another barrier as well, right? If you feel like you're just like you're never going to know enough about the issue, it's another reason to just stay away.
Yeah, it's a really good question, Karen. I think there are two components of this. There's the listening component, right? Taking in information so that the interventions that we're creating are actually relevant to the context that we're operating in. And then there's sort of the deployment of the information in the intervention. So I think, for the purpose of the time, I'm going to focus more on the deployment of information. I think you're right. The traditional model of CME courses that are updated rarely, if ever, and it's sit on a website, and you got to sit through an hour and a half, and you can't 2x speed it, so you're sitting there for so I think that model, it's over, right? We're not changing behavior that way anymore. You have to meet people where they're at, and unfortunately and fortunately, a lot of information is being shared digitally now. Yeah. Right. So one of the things that we learned with X-Waiver was you have to go to the digital watering holes, if that makes any sense. Where do people go and hang out and get their information? We have found, so emergency physicians really like a couple of blog posts. We need to be in those blogs, right? We found a couple of really exceptional influencers in emergency medicine. We need to be giving them talking points. They need to be creating content. We're not going to tell them how to create it, but we're going to give them the content and they're going to push it. We need to be making it very easy for these things to be remembered through the use of mnemonics, like you just saw. So it's kind of like a guerrilla marketing approach would be the way I would describe it. And that is effectively, I think, the way that we're really going to get to saturation in terms of information.
Great, thank you, thanks. And it's a continuous process. We shouldn't assume the one-time training or one message is going to do it.
That's right. And I'm sorry, that's the part about the listening piece, right? You have to continually be, okay, we shared this information. Now let's listen in. Do we need to change or adjust this? Do we need to kind of, customize this in any better way? So yes, absolutely.
Great, thanks. We had a couple of comments about concerns with provider malpractice insurance, and a couple of people saying they've had the experience of their insurance going up if it was when it was learned that they were treating patients with addiction or providing addiction medicine care. I wonder, Wes, from both your perspectives on the MD and JD side, is this an issue that you've seen?
Yeah, people have mentioned that, but again, that the state authorities can play a major role, and then insurance commissioners can play a major role. And I'll just point out, we've got to carry the message to everyone. If we're going to make this even though the public health emergency is no longer the issue here, we've got to get people involved. The operating assumptions that somehow you're at greater risk than the doctors who give people unlimited prescriptions for opioids, and oops, we've got someone who's opioid dependent. That's not the case. So by discriminating against, there are ADA issues, there are, in addition to dealing with the actuarial position of the insurance commissioner, they should be asking, why are you charging more for something that doesn't necessarily give you greater liability? In fact, OBGYN and neurosurgery have greater risk than treating someone with a substance use disorder. But we need to have those actuarial data, and the insurance commissioners need to be involved. And I think both at the state and federal level, state authorities and federal authorities can bring that discussion. If this is a growing issue, we need to catalog that and bring that to Office of National Drug Control Policy. What are you doing about malpractice insurance? Since they do federal policy, they may not be able to pass laws per se, but they can raise that issue. We got a number of bills that are being introduced in Congress for this, that, and the other. They could ask questions about that. So I think we should push back on the insurance, malpractice insurance. It says essentially, because someone's got an opioid use disorder, by definition, they're at greater risk than someone who has got cancer or someone who's got other complicated conditions similar to.
Definitely sounds like another audience for us to be thinking about at FORE as well, right, in terms of communication.
It's an all hands on deck issue.
It is indeed. I realize that we are now just past 4:30 Eastern time, so unfortunately I think we are going to need to come to a close. I want to first thank Dr. Clark, Dr. Martin, Dr. Weinstein for incredible presentations and discussions, as well as my program director, Dr. Shatskis, for working on really hard on putting this webinar together. We are going to do our best. There are so many good questions and so much great interaction in the chat. We're going to do our best to follow up with our presenters and get responses to a few more of the questions put together and posted on our website, along with the presentation and the link to the webinar recording. The questions will take us a little bit longer than the recording and the presentation, but we look forward to continuing this discussion with many of you. I think we could go for another hour, so maybe we'll give that some thought and bring people together again. Thank you. Thank you all again. Have a good afternoon. Stay safe.